Yeah, we are live. We can start.
I think we'll wait for like 2-3 minutes more. Then I'll start. Good afternoon, everyone. So myself, Sanya, Director of SRESOG at AMC board level. I welcome everyone here for this seminar. I hope everyone is very excited for it. So basically, we'll talk about reproduction, which starts from physiology and goes up to the clinicals. It is very useful for the beginners as well as the final year students who are gonna just start their clinical uh, clinicals after they end their MBBS. And then this seminar is designed to offer something for everyone, covering everything from the foundational physiology to common clinical conditions like PCOS and infertility. And I also just wanted to let you know here, these people are not only from Mauritius or only from my college. It's a global event, and people have joined us from like all around the globe. So let's welcome everyone here. Then it's now my absolute honor to introduce our speaker for today, Dr. Shweta. She is highly accomplished obstetrician and gynecologist, a skilled laparoscopic surgeon, and an expert in infertility management. She holds multiple prestigious qualifications, including MBBS, DNB, DGO, FAMAS, FICOG, and Diploma in Art. Currently, she is serving as an assistant professor at Lokmanya Tilak Municipal Medical College and General Hospital Sion in Mumbai. She brings over 12 years of rich teaching experience at both undergraduate and postgraduate levels. Her dedication to education and excellence in patient care makes her the perfect person to guide us through this important and often complex topic. Actually, it's a very complex topic, but she'll make easy for us. So, without any further delay, please join me in welcoming Dr. Shweta on board. Let's give her a warm round of applause virtually. I hand over to you, ma'am.
Thank you so much, Sanya, for the kind introduction. Um, Thank you for this organization for giving me opportunity to speak for students. I myself is an assistant professor in Sion Hospital, and our job is to teach students, right? And it is really a great opportunity to communicate with all over India. Thank you so much. So today's topic is reproduction from physiology to fertility. Just for a second. Yeah. So the today's topic learning objective, what we are going to learn in this topic is anatomy of male and female reproductive system, hormonal regulations, physiology of reproduction, fertility, causes of infertility, how to diagnose infertility, management, and the future beyond. Coming with the male infertility, before touching the topic, let's explore what are the biological factors which is going to affect infertility. So there is age, the stage of growth or development, and the changes in the hormone level. Second is environment, the climatic condition, stress factor. Third is health, parasitic load, infection, immunity. Fourth is nutrition, stage of production, then quality of the food products what we are eating, and the management. That is castration, disbudding, or handling of anything. So these all factors are going to affect the fertility. First, what we are going to learn is the male reproductive anatomy. If you look at the picture, what we could see is the external and the internal genital organs. Looking for the external genital organs, you can see the penis, urethra, and the scrotum. The scrotum carries the genital organs of the male reproductive system that called as a testis. Internal factors is testis, epididymis, vas deferens, glands. There are three types of glands which we could see. There is a seminal vesicles, prostate, and the bulbourethral gland, also called as a Cowper's glands. If we take the cut section of a testis, what we could see, the testis is divided into multiple lobules, and each lobule has 2 to 3 seminiferous tubules. These seminiferous tubules which join together and they form a retitestis, which further connect to the epididymis with the help of efferent ductules. This is entire epididymis which is divided into head, body, and a tail, which further opens into vas deferens. If we take the cut section of the testis, what we could see is the seminiferous tubule cut section, which is lined with the stratified squamous epithelium, which consists of two types of cells. This nucleated cells, which is called as a spermatogonia, and there are long tubular cells, which is called as a Sertoli cells. Let's see how they are going to function. So this is the cut section of the ovary. You can see there's a seminiferous tubule here, and if we cut open the seminiferous tubule to 1/12 of the section, what we could see is there is a spermatogonium here in the baseline. Okay, this spermatogonia, they undergo mitotic division and they form a primary spermatocytes. These primary spermatocytes, they remain in a meiotic phase. They divide after the first meiosis into the secondary spermatocyte. You could see there are two secondary spermatocytes. These secondary spermatocytes which undergo second meiotic division and they form a spermatid. They are haploid number of sperm cells which further develop into the sperms. If we look for the sperm pathway, there's a small mnemonic which is given as called as 7-up, which stands for seminiferous tubule to epididymis, vas deferens, ejaculated duct, then comes as a urethra and a penis. So the seminiferous tubule, it forms main sperms. The maturation process is occurring in the epididymis. So just if we go to the previous structure, so there's a seminiferous tubule which is forming the sperms. Okay, the sperms, they grow here, they form here, and then they go in an epididymis where the maturation process takes place. And once the maturation process is completed, what happens is they are carried by a vas deferens here, right? So ejaculation, it is coordinated by the sympathetic nervous system. So when there's an ejaculation, the sperms, they're mixed with the seminal fluid, which is supported and secreted by 3 glands. We have already named them. So these glands, they are prostatic, corpus gland, and a seminal vesicle. They are very enriched antioxidant fluid, which help in the sperm secretions. If we look for the hormonal regulation of a spermiogenesis, so everything is under control of hypothalamus. It releases gonadotropin releasing hormone, which acts on a anterior portion of a pituitary gland, which releases 2 hormone, FSH and LH. The role of FSH, that is follicle stimulating hormone, that causes Sertoli cells to produce more of inhibin and a spermatogenesis. Inhibin has a negative feedback control over a anterior pituitary, whereas spermatogenesis lead to formation of the sperms. The second hormone is called as LH, luteinizing hormone, which stimulates Leydig cells to form a testosterone. This testosterone has a varied target tissues. Its main function is to formation of secondary sexual characteristics. Also, it maintains the axillary reproductive organs responsible for the sex drive, protein synthesis in a skeletal muscle, and bone growth in adolescence. This hormones called as testosterone has a negative feedback mechanism on an anterior pituitary and on a hypothalamus, which controls entire HPO axis of a male reproductive tract. That's about the male. Now we'll start with the female reproductive system with the anatomy. The female reproductive system has internal and external organs. External being a clitoris, labia majora, minora, vestibule, here which is depicted in a picture. You can see in this picture. Whereas in internal organs, they consist of uterus, fallopian tubes, ovary, cervix, and vagina. If we see the gross picture of this uterus, we could see there's a uterus, which is on either side, there are long fallopian tubes. The fallopian tubes has various portions. They're divided into 5 parts here. Then the uterus in continuation, it forms as a cervix, which opens into the vagina. On either side of the ovary, it is connected. Either side of the uterus, there are ovaries, which is connected to the uterus by ovarian ligament. If we see the cut section of ovary, what we could see in a lateral sectional view, the ovary, if you cut open, it is made up of cortex and a medulla. The outer lining is tunica albuginea. The cortex is the main reservoir of all the follicles, whereas the medulla has all blood vessels supplying it. Going into the detail, these follicles, they are called as the primordial follicles. If we start with this, you could see this is the primordial follicles, which develops and grows to form a primary follicle. As the maturity achieved, they are further developed into primary and a secondary follicle. Once the follicle is mature enough, it ruptures open at the time of ovulation, releasing the ovum, and further develop into the corpus luteum, which releases hormone progesterone. And if there is no pregnancy, this corpus luteum dissolves and it forms as a corpus albicans. So this is the oogenesis process, where at the time of birth, this all primary oocytes are inactive and they are arrested in a meiosis 1. As the female reaches to the puberty, this primary oocytes, they starts grow up, and at the time of puberty, there is a release of ovum where the primary oocytes, the meiosis 1 is completed and it is arrested in a meiosis 2. At the time of meiosis 1, when the primary oocyte divide, it forms as a first polar body with the secondary oocyte. Suppose there is a ovulation and the fertilization takes place with the same ovum, the meiosis 2 procedure is completed and there will be release of second polar body and the ovum is formed. So that's how the fertilization and ovulation cycle go hand in hand. The endocrine control of female reproductive system, again, it is depend upon hypothalamus and anterior pituitary glands. The hormone remains same, follicle stimulating hormone and a luteinizing hormone. So how it works? So the hypothalamus, which releases the gonadotropin releasing hormone, which acts on the anterior pituitary to release FSH and LH. This FSH, as per the name, it is a follicle stimulating hormone. It causes growth and the maturity of these ovarian follicles. These follicles grow in size and there is a release of estrogen by the cells, linings. So once there is a estrogen peak, what it causes? It stimulates the anterior pituitary to release LH. So there will be a LH surge. So you could see there's a LH surge. The LH surge is responsible for the ovulation. Once there is a ovulation, the remnant ovum is released, ready for the fertilization, and the remnant of the follicle, it develop into corpus luteum. And if there is no pregnancy, the corpus luteum, it causes formation of corpus albicans. Suppose at the time of ovulation, there is a fertilization and this corpus luteum, it retains its size, releases hormone progesterone and the pregnancy continues. As this cycle run in the ovary, similarly, there's a changes which is happening in the endometrial lining of a uterus. So what is happening here? The endometrial lining, initially when there is a FSH hormone secretion, this lining is slowly starts increasing. As this follicle grow, it releases estrogen. So what happened with the effect of estrogen, the lining starts to thicken and increase in the size. When there is an ovulation, the progesterone hormone dominates and causes release of progesterone. There is a stability of this endometrium, and in secretory phase, you could see there's a tortuous blood vessels which are ready for acceptance of the ovum. But if there is no fertilization, what will happen? This all secretory phase, the thickened endometrium, it will break down and that leads to menstruation. So in a female, there are two cycles which run hand in hand. One is ovarian cycle and second is the uterine cycle, which is responsible for the menstruation. Even though there is no ovulation, what will happen? If there is no ovulation, there is no progesterone hormone secretion. So this FSH hormone still is going to act. The follicles are really going to grow. There will be increase in estrogen. The cell lining is going to grow. And because there is absence of progesterone, there won't be any menstruation. So when such female who are not ovulating, which is called as an anovulatory cycle, when they will bleed, so they will bleed when the endometrium grow really in good size and automatically because of lack of progesterone, there is no stability of holding this endometrium in a uterine cavity. It will break off and leads to menstruation. That's why it become irregular. No one can predict when the bleeding will occur. Sometimes it takes 1.5 months, sometimes it takes 2.5 months. That's how, because of lack of ovulation, lack of progesterone, the cycles become irregular. So what will happen when the egg is ready and the sperm is ready? They will fertilize, undergo mitosis and form an embryo. And once the embryo is formed, so this all process of accepting the embryo, it is happening in the fallopian tube. So is very main predictor or a responsible portion of a female reproductive tract, that the sperms, when it is accepted, it is traveling across the uterus, across the endometrial cell lining, and they go towards the fallopian tube, where the fallopian tube has already captured a ovum at the portion of ampulla, that is a part of fallopian tube, where the fertilization takes place. And once the embryo it is formed, it starts slowly growing in a size and it reaches the endometrial cavity where the implantation happens and the process of pregnancy starts. So this fertilized egg, which you see, it further divides into 2 cell, 4 cell, 8 cell, 16 cell, and such a stage goes on and it forms a morula and a blastula. This blastula, once it is implanted in the uterine cavity, it forms various changes in a morphology and it forms a fetus. At 20 weeks of gestation, the full fetus formation has already happened, and after 20 weeks, only the growth and development of individual organ happens and the baby forms. So that's what is all about infertility. Now we'll see what is infertility and how we are going to deal with it. So when we see infertility, the goals of our learning thing is what is the infertility definition and basic goals and management, causes, how to evaluate a couple for male and female infertility. So by definition, infertility is inability to achieve pregnancy after 1 year of regular unprotected intercourse. The husband and wife has to stay together for a year and they should have a regular unprotected intercourse, and despite of that, if they are unable to conceive, it's called as a infertility. The infertility, it has two types, primary and a secondary. Primary means she never conceived in her lifetime. And secondary, she must have conceived, but she didn't had a live birth, or maybe there's an abortion, or after first pregnancy, there's a long period has gone and now she is not able to conceive. So that is what the secondary means. She has already conceived or aborted, but after that, she is not able to conceive. That is called as a secondary. Then there's a subfertility, means pregnancy achieved after 1 year of regular unprotected. It takes time, but still she is fertile, so it's called as a subfertility. Then there's always two things they are asked: fecundability and fecundity. What is fecundability? Is probability of achieving pregnancy in one cycle is a fecundability, and fecundity is achievement in a one ovulation. So when we see the causes of infertility, if we look for the couple, 35% of the problems they're associated in a male. So the male infertility is account about 35%, whereas unexplained being 10 to 15%. So if you see 40 to 45% is the main female. So it is not more like if there's an infertility, mainly the female is responsible. No. If you see 45 to 50% is the female infertility and 35% is the male infertility and rest is unexplained. So when we look for the causes of female infertility, so female, the structure which is formed by the uterus, fallopian tube, ovary and a cervix. So depending upon that, the causes are involved. So if you see the uterine factor, the main role of uterus in a pregnancy is the implantation. So for implantation, you need a good bed of endometrium. So if there is unfavorable endometrium, or the endometrium is disturbed with the tuberculosis, or if there's a tumor growth, or there's some problem in the formation of the uterine cavity, that leads to infertility. Second is ovarian factor. Suppose if there is no release of egg, how the female will get pregnant, right? So for an ovarian factor, the main problem is anovulation. So anovulation happens because of hormonal factors or in diseases like a PCOD. Tubal factors, when the tubes are damaged because of adhesion, previous surgery, endometriosis, infections that lead to infertility. So we'll see each and everything in detail here. So for any female to conceive, the ovulation is the main criteria. If the ovulation is not happening, it's called as anovulation. According to WHO, there are 3 groups they have made to classify ovulatory disorders. The first being hypothalamic pituitary failure, where the gonads are not developed because there is no hormone production. So these are the example: Coleman-Sheehan's, idiopathic deficiency, or some tumors. Second group being hypothalamic pituitary dysfunction. Here the gonads are developed, only the hormones are in less form. So example is a polycystic ovarian syndrome. Third is hypergonadotrophic hypogonadism, means there is some problem in the ovaries, either the ovaries are not formed, like a Turner syndrome or ovarian failure. So, which leads to even the hormones are active, but the ovary, the end organ is not functional. That's why there's a problem. The first is PCOS. It's very common. It is seen in most of the, I think, 50 to 60% of the young female, they are affected. So how they present? They present with irregular periods. Then there will be hirsutism, extra facial hair loss, acne, fatigue, irregular periods. Then there's a sonography that shows a cyst. So how it is happening? It is happening, there's obesity and insulin resistance is a main associated things in a PCOS that has a genetic base. So what happened in the PCOS? There's a no ovulation. So there's no ovulation. So what is happening with there's no ovulation? This theca cells that produces more of androgens. This androgen causes adipose tissue to increase in the size and increase in number that leads to obesity, right? Then second, there will be effect on a pancreas. This pancreas, what happens when we eat? So the insulin acts and the glucose get utilized. But here there's a resistance to the insulin. So whatever we eat, the insulin is increasing in number, but it's not able to control the glucose level because it is not functioning. So the pancreas identified as a problem, the glucose is still not utilized. So it produces more and more insulin. It's called as a hyperinsulinemia. That's why there's an increase in the insulin in the body of a female. So that insulin, what happens? Insulin acts as a growth hormone and it further increases in the size of the fat cells. So there is a correlation between the PCOS and obesity and a hyperandrogenism. Then second is premature ovarian failure. What happened? Generally, the menopause, which has to become at age of 50 or a 55, it comes early. So there is ovarian dysfunction. There's a low estrogen in the body. And all menopausal symptoms the patient may experience. There is absence of periods, night sweat, dryness of vagina, and lowering of sexual appetite. Third is luteal phase deficiency. There's a decrease in the hormone productions called progesterone. So what will happen is a bleeding after ovulation is a specific problem that comes with bar periods. They'll get 2 times periods they'll have. So at a time of ovulation, they'll have a period like bleeding, like a spotting. So there's a low levels of progesterone in the body. There's a breast tenderness, and such female, they experience recurrent miscarriages. Then Turner syndrome is called ovarian dysgenesis. Here's a chromosomal problem. The sex chromosome 1X is absent. So there is a ovarian dysgenesis and their variations are there is a mosaicism. So depending upon the involvement of a chromosome, it will present. That about ovarian factors. Second is tubal factors. Tubal factors which include salpingitis is an infection of fallopian tube, tubal malformation, endometriosis, and hydrosalpinx. What happened in endometriosis? There's a endometrial tissue outgrown outside the endometrial cavity. So it is all over, like it is on the posterior surface of the uterus, in an ovary, okay, in a POD, on a uterosacral ligament. So that causes bleeding during the time of menstruation. This bleeding causes pain, adhesion formation, cyst formations, and severe dysmenorrhea. It's called triple dysmenorrhea seen in cases of endometriosis. Second is PID. PID is when there's an infection of upper genital tract, which include ovary, uterus, fallopian tubes. It involves thoroughly uterus, including myometritis, endometritis, and a parametritis. Risk factors being chlamydia infection, gonorrhea, multiple sexual partners, and so. So here there's also involvement of the endometrial lining leading to endometritis, causes irregular bleeding and a pain. The treatment being antibiotics, hospitalization. If there is some tube mass, that is tube-ovarian mass formation, pus formation, you might have to require a surgery. The risk which is arising from the PID is a chronic pelvic pain, infertility, ectopic pregnancies. The next is a pelvic adhesion. There's a tubal adhesion either with the history of the previous surgeries or infections. Then the hydrosalpinx, there is an inflammation of a fallopian tube and the fluid collections. So the inner cilia, which is lining the fallopian tube, it lost. So the motility of the fallopian tube is affected and there are more chances of infertility, or even if the patient conceives, there are more chances of having ectopic pregnancy. Then coming to the uterine factors, uterus is responsible for the implantation, and if there is no implantation, this lead to repeated miscarriages. The first is uterine malformation. There is multiple anomalies formation while the forming embryo during the embryogenesis. So there is a Mullerian agenesis, no uterus form. There's a septum. There's an arcuate. The upper portion is slightly curved inside. Sometimes it's only one horn is form is called uniconvert. Sometimes the two horns are formed, but there is no, unification. So they are called as a biconjugate, and there's a uterine didelphys, means along from the starting from the cervix, the two uterine cavities, two separate uterine cavities, and each cavity will have a one fallopian tube and a ovary. Then there's a uterine Sion case. There's a previous surgery, like a uterine curettage, myomectomy, or infection that causes a stickiness. There's a adhesion formation inside the uterine cavity is called as synechia. Then uterine tumors like a fibroid, adenomyosis, polyps that may lead to infertility. Then endometrial hyperplasia. There's excess of estrogens in the body that lead to endometrial hyperplasia and heavy bleeding. Treatment of uterine factors is main. If there's an infection, you give antibiotic, hormonal, or surgeries in the form of hysteroscopy, laparoscopy, right? Then next factor is a hormonal factor. The two hormone which is extremely important for a female is a prolactin and second is thyroid. So if there is a hyperprolactinemia, so what will happen when there is an increase in the prolactin hormone? It disturbs ovulation. Similarly, when there is a hypothyroidism, when the thyroid hormone is not formed or is a deficit, it leads to decrease in a chances of ovulation. Then other factor, there is anti-sperm antibody and vaginismus. Anti-sperm antibody, the immunity play here a major role where the female body is not accepting the sperm, it considering as a foreign body and it destroys it. So there's no sperm which is accepted. And second is vaginismus, when there's a severe contraction of the pelvic musculature and the female is really uncomfortable having a sexual activity. If there's no sexual activity, no reproduction, right? So when such couple comes to you, how you have to evaluate, you have to take thoroughly history. You have to find out what will be the cause when you take a history. Is there a problem in the ovulation, tubal factor, uterine factor, or some other factor associated? The first and foremost is you have to see the structure which is given, the reproductive tract which is given, the uterus, tube, ovary, everything is there. First is they're intact, she is menstruating. Then we have to confirm that she is ovulating or no, right? We have to check the tubes are okay or no. So the tubal patency has to be confirmed. So we'll see each and everything. So basic investigation, if it includes CBC, ESR, look for the infection, sonography, hormone assessment, checking for the tube for the tubal patency, uterine cavity, and then we have to see the ovarian reserve. Really, the eggs are there enough for a fertilization and peritoneal factors. For the tubal patency, the most commonly test which is done is a hysterosalpingography. Here the dye is injected through the cervix and the outlined uterine cavity and the fallopian tubes are seen. Second is sonohysterography by giving the water inside, and third is laparoscopy and hysteroscopy. You can see actual by giving the water and by visualization directly through the procedure. So by hysterosalpingography, what you could see, you can find out the uterine problems or a tubal problems. So these are the few pictures I have kept here. The first picture is fibroid uterus. You could say there's a filling defect here. It's maybe some fibroid or a polyp. Then second is synechia. You see the irregular triangular cavity is filled. There's a synechia. Here also you see the irregular structure. Then you can see is a filling defect. It's a smooth, regular filling defect. Mostly suggest your fibroids. Then if you see the tubes, here the pipe or stem appearance, which is seen in a, very thin pipe structures of fallopian tube. Sometimes it is a golf club tube, sometimes it is beaded, which is classical for tuberculosis. This is a normal HSG where you can see the triangular shaped cavity and this fallopian tube, which is spilling the dye outside, right? That is a normal thing. And this is, you see the hydrosalpinx. What you see in the hydrosalpinx is the tubes are really ballooned out and there's no spillage. Everything is getting collected in the fallopian tubes, right? The AMH has again a weightage because it gives the knowledge about ovarian reserve. It is produced by the granular cells of preantral and small antral follicle, and it strongly suggests, correlated with the primordial follicle pool, is considered as the earliest and the most sensitive marker nowadays, because with the age, the ovarian reserve decreases, but it will tell you the quantity, but not the quality of the egg. So how to assess the ovulation? The olden technique, basal body temperature, just at a time of ovulation, there's a rise in the temperature. Mid-luteal progesterone, the level of progesterone rises. For that, you have to do a serial progesterone test. Third is urinary LH. There are LH kits are available. At the time of ovulation, you check with the urine, like a UPT kit, urine pregnancy test, same. So urinary LH, that LH peak, and mostly you are going to ovulate next day. Then serial sonography, you can do a serial sonographies where you can monitor the follicle and ovulation, and endometrial biopsy, which will give you knowledge about the secretory phase. Secretory means there's a release of progesterone, right? So what will be the management of this female infertility? So first is lifestyle changes. If there's any problem like obesity, addiction, everything needs to be changed. Then once you diagnose it as an ovulation disorder, definitely you have to give drugs for ovulation inductions. You can take the help of IUI, IVF, tubal blockage, go for IVF because tubes are not working. When the roads are not there, how you are going to reach destination, right? So we have to bypass those things. So directly we can go for IVF. And if there is a problem in the uterus, you do some surgery, try to repair it, not possible, you do IVF with surrogacy. You have to render fetus for this uterine problems. That's all for female infertility. Now we are going with the male infertility. The causes are divided into pre-testicular, testicular, and a post-testicular, and a sperm morphological problem. Testicular causes mostly if there's a chromosome abnormality or patient has some varicocele, hydrocele, which is pressing really on and affecting the sperm production. And suppose the patient has taken chemotherapy, so all these gonias, spermatogonias, they are destroyed. So maybe that is a cause. Then second is the post-testicular. Once the sperms are produced by the testes, still there's a problem in the carrying pathway. So there may be some seminal duct obstruction, vas deferens obstruction, or some pathology. Third is sperm abnormality. There may be a problem in the sperm formation, either in a concentration count or a motility or in a morphology. So how the male infertility will come? They may have erectile problems. They come with the varicocele, hydrocele. There will be a changes in the semen. Then there's a low sex drive or a small testis. So this is an assessment of a male partner. You have to take a thorough history of, fertility history, previous surgery, any family history, any urogenital problem, any infection, any surgery, habits, alcohol, all these things, even including the occupation, everything has to be taken care and asked thoroughly to assess the problem and reach to certain conclusion. So how we are going to assess? By doing a physical examination, hormone analysis, and a semen analysis. So looking for the physical examination, general examination, suppose patient is obese, diabetes, all these factors has to be taken care. And specific is urogenital examination with the expert here to assess the all external and genital organs and do a sonography to look for the internal genital organs. Then the semen analysis which consists of volume, sperm concentration, total motility has to be assessed and the reference levels are given. The WHO recently is 2021, which has given the ideal reference level. So we have to compare by doing the semen analysis. There are various problems in the semen. There may be oligozoospermia when the concentration of sperm is low, asthenozoospermia when there is a motility problem, teratozoospermia when the morphology is problematic, oligoasthenoteratosis is a combination of about three. Azoospermia when there is no spermatozoa, and aspermia means there is no ejaculation. The CASA is a computer-assisted semen analysis, which has replaced the traditional semen analysis, where it is a computerized and magnified view of sperm morphology can be assessed with this. So how you are going to manage? So management always start with the lifestyle modification, medical management. You have to supply the antioxidant vitamins, and there are other ART techniques which we can help the patient. There are certain 10 to 20% of the causes where the actual reason is not known. It's called as unexplained. So mostly it is associated with the genetic abnormality. There's a chromosome abnormality in the egg. There's some embryos problem, or there's an implantation failure where we actually have to take the help of ART. So what do you mean by ART? Is a assisted reproductive technology where we are just changing the natural process and taking the help of artificial methods. So who are eligible candidate who cannot conceive naturally, or we are taking treatment not able to conceive. So those are the candidates. And there are various types of ART. There's a ICSI, donor egg, surrogacy, and a PGT. So I'm just quickly going to see brush all the methods. So this is the artificial insemination, means the patient is asked to collect the semen, the male partner, and then at the time of ovulation, once you confirm with the special cannula, the sperms are injected after the preparation. There's a special preparation which is available, and they're injected into the uterine cavity. That's called as the artificial insemination. And in vitro fertilization means the egg is collected from a female, sperm is collected from a male, and they are processed outside, they are get fertilized, the formation of embryo, and such embryos when they are transplanted is called as a in vitro fertilization. So here we just see the what is the IUI. I just said the female, the ovarian stimulation is given, the male, the semen preparations are done, and once it is processed, it is introduced into the uterine cavity. Second is in vitro fertilization. Here the again females are induced with the ovarian stimulation. The follicles are formed, then they are selected, they are punctured, they are collected with the sonography, and they are preserved. Here the male, the semen is collected, the sperms are selected, either you do ICSI or directly inseminate, and you form the embryo, you culture those embryo, and then transfer embryos. Then what is PGD? PGD is pre-implantation genetic diagnosis. Means what? This embryo, once it is formed, we are just going to take a small biopsy and going to see the genetic material, and we are going to analyze for a chromosomal alteration. So by which we can select the healthy embryos for a IVF. What is the difference between the classical IVF and ICSI? In a classical IVF, here the ovum, it is the egg which is we collected, we put selection, we put a spermatozoa all around, and the spermatozoa find its path, the best one goes in. But in ICSI, we select the sperm, we make one sperm to introduce into the oocyte with the small people needle you see here, and then the sperm which is introduced, and then there's a fertilization inside that's called as a selective with the one sperm is called ICSI, which is different from the classical IVF. Here again, the once it is micro injection, and once the fertilization embryo, you can go for a IVF. There is additional technique called as MAX, PGD, and IMS. These are selection of the normal morphology. The success rate differs depending upon the institution and the age levels, and the possible risk factors are also there, like OHSS, ovarian hyperstimulation. Sometimes the ovaries become very huge in size, or there may be a multiple pregnancy, miscarriages, abortion, or ectopic pregnancies. Then coming to the third party reproduction, which is called the donor assisted reproduction, means when the couple has to take a help of third person, either in a form of female who is giving egg, or a male who is giving sperm, or an embryo, the some couple is only giving embryo, or a surrogacy, or the female is offering a uterus for a implantation. So what are the indication of a gamete donation? There may be a genetic alteration, poor gamete quality, low ovarian reserve, multiple miscarriages. So all these are fertility treatment options are available in the form of IUI and IVF. So talking about the surrogacy means you are just renting a womb. Means what? The partner, the intended parents are not able to conceive because of many factor, or maybe they are single, lesbian, gay couple, or what or not. So, and they want to have their own child. So they are sharing the genetic material, but they are renting womb of someone, and where the baby is, rare, and the baby is formed. That is called the gestational carriers or surrogate mother. But there are separate laws for the separate countries. One has to take care what country allows. Then there's a cryopreservation. Cryopreservation is a two processes called freezing and a vitrification. Freezing, it is conventional, like we are putting a cryoprotectant and then it's taking long time, slow cooling process. But here the problem is ice crystal formation, and then that ice crystal might change the structure of that particular gamete. Whereas vitrification is very fast, quick, and in a short time the freezing happens, and it is avoiding the ice crystal formation is a favorable. Only thing is the cost. So this is how the different it's. The egg vitrification, see, we are going to vitrify the egg embryo, but for the sperm, we are going to use the freezing technique because sperms being a very small in size and there are no formation of the microcrystal, with the space for the microcrystal formation. So if you see the cost, there's definitely yes for the sperm to go for a freezing, rest everything goes for a vitrification. Now we are coming with the future of a human reproduction. That is what the basic now what we are practicing so far. So coming for the future, what we are going to see in a future is artificial intelligence is going to come in a ART. So what they are going to do is they are going to do AI with the programmed software is planned and everything is taught to that software, and the software is going to do a gamete selection, embryo selection, and also is going to provide a treatment regimen, right? Then second is the uterine transplant. Uterine transplantation, now they started in India, specifically in Maharashtra and Pune district. So what you see is the female who has no uterus or she lost her uterus for any reason. So such a female, and if she anxious to conceive, she wants her own baby. So that time the healthy womb is transplant from a disease or with the all blood vessel intact. And once she attempts to conceive, mostly goes for the IVF, and such uterus you can keep for 2-3 years once the baby function is over, because everything goes with the immunosuppression. Then there's a non-invasive pre-implantation genetic testing where we, in a traditional way, we take a biopsy from a embryo. Here it is the embryo cultivation, and then we are going to see the results. Then there's a womb, which is artificial womb formation. It is in a research, right? Then there's a gene editing technologies and a bioengineered tissues utilized for a development of the reproductive tissues. So if you see this human production, it's very complex and it has a coordinated interplay between the anatomy, physiology, hormone, HPO axis being is the playing the major role, and anything which is disrupting the physiology and anatomy is going to lead the infertility. Our job is to find out what is the cause and give a treatment, and we can take definitely help of ARTs. So that is the end of the lecture. Yesterday I got a list of questions here. So we are going to cover one by one in quick mode. So the questions were asked, what are the STDs? So these are sexually transmitted infections, the chlamydia, gonorrhea, syphilis, many more. And this, just we saw there's a formation of PID and leads to infertility. What are the cultural and religious belief impacting reproductive health policies? See, mainly it is towards the contraception and a fertility treatment. Some religion restrict contraception, like Catholic and all, they don't want to, terminate pregnancy. So they restrict. So depending upon the cultural beliefs, and generally when we are dealing with the culture, we cannot, they all are so sensitive. So we have to take everything in account and you counsel and do it. Then hormonal acne after stopping birth control pills, yes. OC pills, when you give, what it causes, it causes cessation of, androgen excess and everything. It causes everything, all hormones, they go to the base level and there's no surge, no androgen, no testosterone, no LH. So this androgen, it is responsible for the acne formation, the glands which are under the control of androgen, and there's no androgen, no acne. Definitely, yes. Do menses synchronize with the lunar month? No conclusive evidences support menstrual cycles. uh, they vary depending upon the ovulation timing. It is not like sometime they get 28, sometime they 30, but they are regular. So you cannot say that. Dietary habits for PCOD, definitely dietary habits is, I think, for it's advice for everyone with a low glycemic, high fiber, anti-inflammatory, balanced micronutrient. And the main is exercise. Exercise is important because that increases the insulin sensitivity. Then male infertility prevalence improvement that we have just seen. Female egg freezing and AMH that we have just seen. Laparoscopy, yes, laparoscopy has a role because here we are going to directly visualize the interior of a structure, and yes, it has a role in a correction of the surgery if there's any problem. Endometriosis and a uterine neoplasm. So generally, endometriosis being a benign one, but it may increase the risk of endometrial ovarian cancer. So you need to have a hormone therapy and surgeries if required. Microplastics and a male reproductive capacity. Yes, microplastics are really bad and it disrupts the endocrine function, increases oxidative stress, and also decreases the male hormone production. So always we suggest that you should really reduce the plastic exposure. Okay. And what is IVF? We have just seen PCOS and OC pills that we have just seen managing hormonal imbalance without medication. Yes, you can manage, but for that you have to be, be stick to the basic, like you have to follow the diet, exercise, stress management, sleep pattern correction, everything. If you do it, in olderness where they were taking medicine, now we are taking medicines because we have changed everything. So if you are strict to the basics, then I don't think, but it will definitely take a time, and the persistence is the key. PCOD and irregular periods. We have just seen why there's a PCOD and why there's an irregular period. What is the difference between PCOS and a PCOD? PCOD is just a sonographic picture where you see there's a ovarian, follicles has grown in size and that the multiple follicles develop. PCOS is a syndrome where you get involved with the metabolic syndrome. Okay, it is a serious version of the disease. Then early signs requiring medical advice. Yes, when if you think you are obese, irregular periods, pain, hirsutism, infertility, please go to your doctor. Hormones and differential action. Yes, hormone have a specific receptor. Some are steroid receptors, are a nuclear receptor. Peptide hormones has a membrane bound. The type of receptors and their choices and how they're going to act. So yes, PCOS has an impact on infertility, and prevalence is increasing because of the change in the lifestyle. And that's why I'm just telling you, follow this diet, exercise, weight loss, and sleep pattern. Prevention of UTI in pregnant. Yes, the female has a short urethra and sexual activity, poor hygiene, low estrogen at the time of menopause. All these are conditions which is lead to more chances of UTI. If you see the urethra size in a male and female, the female has 20 centimeter, whereas female has 4 centimeter. So that's why the females are more prone for a UTI. Science behind circumcision. Yes, removal of the penile skin. What happens? There's a smegma formation, and this smegma has all dirt, so that reduces the UTI risk, HIV transmission. It is said by and also infections. So yes, it removes a moist environment for the pathogen and reduces those things. But it's debatable. See, ethical consideration has to be taken care versus a medical. It is debatable and community based, obviously. The one who has not done circumcision take good care of the health, no problem, absolutely no problem. Nothing is compulsory here. Can lean people have PCOD? Yes. PCOD, there are lean and obese PCOD. So lean people, they have more insulin resistance. Then current common reproductive health cases, rising PCOS, the microplastic and toxins, post-COVID, male fertility, everything is rising only. Safer alternative to PCOS medication that we have said already. Endometriosis research, yes, we have done. Approach to infertility, yes, we have done. Insulin resistance in PCOS, that also we have discussed how the insulin resistance occur. Someone has asked period cycle disruptions in Mauritius. Not in Mauritius, if you go to any other country, I think. There's a travel stress, jet lag, climate, diet shifts, everything it changes, your routine changes, and that is going to affect your hormone, main is cortisol and melatonin. So management, you normalize, try to, acclimatize to that country, normalize your sleep pattern, diet, exercise, everything. You monitor cycles. Sometimes you may require OC pills. Okay. And then you get adjusted. Puberty hormones and later fertility. Yes, we have discussed everything this. New diagnostic tools and treatment. We are done. So the AI-based non-invasive endometrial receptivity tests are there, and there are various techniques, mitochondrial replacement therapy, you name it, and they are just studying. All researchers are going. Best cure for fertility issues that we have already discussed. There are so many options are available. Male reproductive health, lifestyle, everything I think we are covered. Infertility, ectopic pregnancy, twin formation. That is a part and parcel of this ART technique. So thank you very much. I think I have covered almost everything. Yes, Sanya?
Yes, ma'am. It was a wonderful session. I must say, like, you literally covered within 50
Yeah.
minutes, which is
Yes.
totally impossible for
Yeah.
anyone else to
Yeah,
do that.
yeah. I'm just running because I have a time limit. So definitely I am trying to touch each and everything which is there related to the ART.
Yeah,
Uh,
because actually it collapsed with like it clashed with our college event today,
yeah,
which is just like informed us like on very short note. So yeah, that's why.
sure. Okay. Thank you so much.
Malika Didi, she's the vice president at the MC board for the James. She'll end this session. And for the participants, please don't leave the meeting without filling up the form. Through that form only you'll be able to get your e-certificates.
Thank you, ma'am, for joining us today. On the behalf of James Mauritius chapter and SRESOG, I would like to extend my heartfelt gratitude to Dr. Shweta Khade, ma'am, for taking the time to share her knowledge and insights with us today. Your talk was not only informative but also deeply engaging. I would also like to thank all the participants for being such a wonderful and attentive audience. A big thank you to our entire organizing team who worked behind the scenes to make this event a success. Also, I would want the participants to fill out the form in the chat box to get the e-certificates and also give a feedback. Thank you once again, ma'am. Have a good day.
Thank you very much. Thank you, Malika.